Hello everyone, my name is Professor Roger O'Sullivan from the Institute of Public Health in Ireland. I'm delighted to be part of the Age Boom Academy and talk on such an important topic. We know that the COVID pandemic has changed everyday life and meant that many more people have gained personal insight into what it means to be socially isolated, lonely or both. My question to you is, will the pandemic help us rethink loneliness? How loneliness is defined, measured, studied, who we think is lonely and why we think they're lonely, and more importantly, how it can be addressed. The structure of my brief presentation will be in three parts. Understanding loneliness, definitions, types, frequency, measurement and health. The second part uses a selection of data to illustrate social and demographic characteristics associated with loneliness. And the final part is a number of considerations and reflections from a public health approach to loneliness. For me, it is important to understand an issue like loneliness to know how to address it, whether this is at a personal, community, structural, or policy level. Loneliness is a negative emotional feeling. It's the outcome of the difference between one's desired and achieved social relations. Loneliness is a subjective, unwelcomed feeling of the lack or loss of companionship or meaningful relationships, emotional or social. The key is to understand the person's expectation. Is it a social connection to an intimate other person? Or is it a connection with family and friends? Or is it a connection with community life or broader society? Remember, one could be surrounded but still feel lonely. Two people may experience the same thing and have very different outcomes. It may be that a person has too few relationships that they desire, or feel they are lacking the quality or closeness that they are seeking. From a public health position, terminology matters. The terms loneliness and social isolation are often used interchangeably. However, they are quite distinct. Loneliness is a very personal issue. It's a feeling of a loss or lack of relationships or connections, whereas social isolation is more objective. Remember, not everyone who is lonely is socially isolated, and not everyone who is socially isolated is lonely. Social isolation is about the number of relations, social interactions, social support structures, and engagements or activities. There are three main types of loneliness. Social loneliness is the absence of a connection with friends, neighbours, and colleagues. Emotional loneliness is the absence of a significant other with whom a close emotional attachment is formed, e.g. a partner or a best friend. And existential loneliness is the sense of longing that cannot be achieved through any type of social interaction. Despite solid relationships, the person still feels empty. There are four frequencies of loneliness. Transient, experienced at such times as bereavement, retirement, moving, becoming a carer. Situational, occurring at certain times of the year or occasions. The COVID pandemic could be considered a situational loneliness. Occasional, a feeling that comes and goes, often seen as a natural part of being human. And chronic, here one feels lonely all or most of the time. Associations with loneliness and poor health or well-being have been established for over 30 years. Evidence suggests associations with depression and anxiety, non-communicable diseases such as cardiovascular disease, health behaviours such as smoking, stress, sleep, cognition, frailty, premature mortality, with the evidence especially strong for depression. Paradoxically, there is a concern that chronic loneliness can adversely affect one's ability to connect positively with others and to engage in interventions that could decrease loneliness. A recent Lancet article underscores the association of loneliness and social isolation with poor physical health outcomes. It moves beyond the view that frailty is associated with loneliness and social isolation and argues that both loneliness and social isolation actually increase the risk of developing frailty. It is important to note when looking at the issue of loneliness that definitions matter, but so too recognizing that different studies can use different scales or single item measures or specific questions. You may not be comparing like with like. Working with colleagues at a national and international level, we recently published a paper that called for consensus in the area of definitions and measurement to help inform policy, research and practice in this area. In this next section, I will use data to look at loneliness before and during the pandemic. Pre the COVID pandemic, there were varying statistics cited about the levels of loneliness in our society and claims of a pandemic of loneliness. Using data from 4 longitudinal studies to a single question, let me compare levels of loneliness between the US, England, Ireland and Northern Ireland. We find in the US in 2010, 11% of people aged 51 reported feeling alone often. In England, 8% of people aged 50 plus indicated that they felt often lonely. In the Republic of Ireland, 6% stated that they felt often lonely. And in Northern Ireland, 5% indicated that they felt often lonely. Let me now turn to the period of the pandemic. For the next few slides, I'm going to use the NORC COVID response tracking study data. It's based on a nationwide poll of 2,279 adults in the US in May 2020. Using the UCLA questions to measure 3 dimensions of loneliness, it asks, how often in the past 4 weeks have you felt you've lacked companionship, felt isolated from others, felt left out? Note, it does not provide a score of loneliness. What we see is that in May 2020, in comparison to 2018, many more Americans reported having felt a lack of companionship, isolation, and being left out in the past 4 weeks than in 2018. For example, 18% in 2020 say they felt they lacked companionship often or very often, compared with 10% in 2018. It's often said that we are all at risk of loneliness. However, some groups are at a greater risk than others. In this slide, you'll see 24% of people aged 18 to 29 say they felt that they lacked companionship often or very often in the past 4 weeks, whilst 13% of people aged 65 indicated the same. We should remember that younger age groups are the most digitally connected. So what does this tell us about connections and loneliness? In this slide, we look at the issue of health. We note that those in poor health are much more likely to report a lack of companionship, often, very often, compared to those with excellent health, very good or good health. 8% with excellent health compared to 45% of those with poor health. In this slide, we see a gender difference, with women more likely to report feeling that they lack companionship often, very often, compared to men. What does this tell us about gender-based connections? Loneliness is also influenced by context, and it is important to understand the factors, structural, social, and environmental aspects that might play a role. During the pandemic, we've witnessed changes to many parts of our lives, our personal lives, our work, our home lives, our social patterns. Over the last 50 years, there's been many changes in America. One of the most striking is the growth of the single person household, from 16.7% in 1969 to 28.4% in 2019. I suspect many within this group found the public health social measures particularly difficult. So some concluding comments, considerations and reflections. The impact of loneliness on our health and well-being must be taken seriously. In addressing the causes and consequences of loneliness, interventions and policy must be guided by robust evidence. In designing interventions and matching them with users, it is essential to understand the type of loneliness, the frequency, and the root cause before moving to a solution. The wrong intervention may have a neutral effect, or it may actually have a negative effect. I believe that greater emphasis is required on a public health approach of primary prevention and population-based strategies in order to promote social health and recognise the social and economic factors that are risks for loneliness. Using a public health framework and a population level approach for prevention can help us consider how we can design social infrastructures, social institutions, and communities that facilitate connections and build social cohesion. The pandemic has challenged and hopefully changed many of the stereotypes about loneliness. There is now a potential to build on the greater empathy, compassion, and concern that has been shown towards those experiencing loneliness, to set in place policies, structures to address the root causes and to support healthy choices. Thank you very much.
Thank you for this opportunity to present a public health approach to loneliness and social isolation. The recent publication of the Consensus Statement on Loneliness in Older Adults in the 21st Century provide a basic understanding as to the state of the field in research in loneliness and social isolation, including measurement, antecedents, consequences, relative risk, and interventions. Independent comprehensive reviews of interventions targeting loneliness conclude that interventions have demonstrated some success. However, the evidence to date is modest. These reviews conclude that there is a paucity of comparative community evidence-based programs addressing the needs of older adults experiencing loneliness. There is insufficient evidence that current interventions demonstrate efficacy, effectiveness, and sustainability for loneliness and social isolation. Loneliness interventions in community settings may be effective in reducing loneliness. However, meaningful process and outcome evaluations are frequently excluded. What is called for are stronger, well-documented theory-driven approaches that are causal rather than correlational and inclusive community focused rather than restrictive. Public health provides a useful framework to understand and investigate the causes and consequences of loneliness and translate research to practice. It is an academic discipline and population-based discipline with a focus on primary prevention and identifying the root cause, in this case, loneliness and social isolation. Public health programs are theory-based and comprehensive and may include policy development, awareness campaigns, and multi-generational collaboration, to mention a few. A public health approach to loneliness has considerable potential for advancing our understanding and addressing loneliness. Loneliness can be viewed as a form of widespread social health disparity. It is based on a biopsychosocial approach and a focus on upstream and downstream determinants of population health. Finally, public health majors' contribution to the translation of research to practice, evidence-based community programs for older adults. It is a process in which accumulated effective interventions that have meaningful impact among older adults are widely disseminated. The impact of the programs on loneliness and/or isolation are evaluated in terms of reach, efficacy, effectiveness, and sustainability.